Welcome to another Polestar Pilates Hour. Looking forward to today. Excited to be with you today. Missed you last week. We were busy teaching the course Critical Reasoning. Of course, you know, that's where we put all these things together. We had a sold out course and it went really well here at the farm. We missed a lot of you. Maybe we'll get you on the next time we do it. All right, well, let's get started. I wanted to do a little review on talking about these types of impairments, and particularly starting off with rheumatology, explaining that and then going into different rheumatic disorders, what they mean, give us a little bit of vocabulary that we can use as we go into the case study today. So starting off with rheumatology, a rheumatologist is a clinical doctor who mainly deals with clinical problems involving joints, soft tissue, autoimmune disease, and heritable connective tissue disorders. Now, all of these we see on a regular basis inside of our clinics. It's just natural for us to have some degeneration, some joint, tendon pain. We probably all have a family member that has some type of degenerative disease. We probably also have members in our family who have some type of autoimmune disease. Rheumatoid arthritis is an example of that. So is lupus, so is psoriatic arthritis, so is multiple sclerosis. These are all autoimmune diseases. And when we talk about the word rheumatism, this is an old word used historically. We often refer to them now as rheumatic disorders, is a non-specific term for medical problems that affect joints and connective tissue. So you might hear of somebody saying, you know, that they were diagnosed with a rheumatic disorder, but they don't know what it is yet. They're still undergoing tests. They're looking at rheumatoid arthritis factors. They're looking at other types of blood tests, genetic tests that would indicate that there is some kind of systemic disease or impairment that is causing this connective tissue and joint disease. So when we look at autoimmune disease, we've talked a little bit about this before, but autoimmune disease arises from our own immune system inappropriately responding against our own tissues. So if you think about it, the immune response, we get exposed to COVID, it should go fight COVID. If we get a cut in our arm and there's some bacteria, our immune system is going to attack those foreign bodies. Those are often called antigens or allergens that are not our body, and our immune system is going to fight it. It fights it with an inflammation process typically, and that inflammation process could be more chemical, where you're seeing things like cytokines. Remember, cytokines are the response, inflammatory response to COVID that did so much damage in the lungs. The cytokine itself is a response to kill the virus, but in its secondary part, it can cause sort of a paralysis of the tissue. And it was that in the lungs that caused the low O2 saturation and led to sepsis and often death. The autoimmunity results from this hyperactive immune system. So this is where an autoimmune disease is tied to an hyperactive immune system. When we think of allergies, for example, an allergen, we get some dust or pollen in our nose or on our skin, and we start sneezing. We might get runny eyes, we might get runny nose, we might cough. All of those are the body's normal responses, first line of defense against an allergen. If we're really allergic or hyper allergic to those things, like say peanuts, or say we're allergic to shellfish or the iodine in shellfish, once we've been exposed to it, our immune system builds up a robust memory of that allergy. And so the next time we get the bee sting, the next time we eat peanuts, we have a very serious reaction that often could result in anaphylaxis, right? This is where people start having difficulty breathing. People who know they're highly allergic to things often carry a pen that is an injection called an EpiPen. So we are very familiar with this idea that the immune system is going to fight things like allergens, pollen, allergies we have with peanuts, those kind of things. It's also going to fight antigens. And antigens are usually dangerous levels of bacteria, viruses, other types of fungi, things that are not in our body. So when we talk about autoimmune disease, we're often talking about our body's inappropriate attack on its own tissues, right? Common autoimmune diseases include Hashimoto's thyroiditis, rheumatoid arthritis that we're going to talk about today, diabetes mellitus type 1, that we often see in children that have diabetes. It is not a metabolic disorder from too much sugar like we would see in diabetes type 2. It is an autoimmune disease that attacks the pancreas and doesn't allow these children and soon to be adults the ability to process glucose in their body. Systemic lupus erythematosus, this is one that is very hard to diagnose because it affects so many different parts of our body. Immunology covers the study of all aspects of the immune system. So when we look at how do we boost our immune system, we're going to talk a little bit about how successful movement experiences and proper diet and sunlight in the mornings and some of these different things that can really help us boost our immune system in a healthy way. Now, when our immune system starts attacking itself, one of the most common treatments is to inhibit the immune system. It is to depress the immune system. And we learned this when we started doing a lot of organ transplants. You would depress the immune system so that the body would not reject the donor organ. When we look at the series of diseases or diagnoses that are often falling inside of rheumatic disease, one that we hear about quite often is fibromyalgia. Now, today we're not going to talk about fibromyalgia. We're going to be talking about one of the last ones there, rheumatoid arthritis. But fibromyalgia is a common condition associated with muscle and tendon pain and fatigue. And typically somebody with fibromyalgia is able to do most of their activities in the day, but they have continual discomfort and pain. They often are triggered more with any kind of emotional triggers, can make it worse. They have difficulty sleeping. And with that, it can lead to other more aggressive conditions like chronic disease or chronic fatigue syndrome. The next one on there is gout. Gout is a disease a lot of you have heard about, maybe a lot of you have had. Gout is where there is a local form of arthritis. It can often be very severe and very painful and tender. It involves the redness of a joint and often associated with too much different types of acids in the body, particularly uric acid. So when the uric acid goes really high, it can create crystalline deposits. They often happen in the big toe, but they can happen in other parts of the body as well. So gout is very treatable, often with a steroid or an anti-inflammatory, and there are some purulines, I think is the name of it, that can be used to treat gout. So we see this quite often in the clinic. Somebody comes in with just a really painful big toe and very red and very hot. So if you see that, very treatable. They can go to the doctor, get an injection, get it diagnosed, and be better within a week. Lupus is a very complicated disease, as I alluded to. This is what Michael Jackson had, was lupus. Refers to several forms of disease of the immune system that affect joints, skin, kidneys. A classic sign is the butterfly rash on the face or the changing of the pigmentation of the skin a little bit. Osteoarthritis, we're going to talk about a little bit. This is not so much of a systemic disease. It is natural aging of the joints and the connective tissue. And I often make a jest of this, not to be inappropriate, but when we look at things like an MRI inside the body and we get diagnosed with arthritis, it could be a little bit like somebody taking a picture of our face as we age and go, hey, you have crow's feet on your eyes. You have, decreased collagen in your eye and around your eye. You have some wrinkles on your face. Your hair is turning gray. And so a lot of us sort of joke and say that the MRI often is just diagnosing wrinkles on the inside. And it's not to belittle the fact that arthritis can be very painful, but it is to make the point that almost all of us over the age of 60 have significant degenerative changes in our joints that are just normal parts of aging, just like we would see in our skin. It doesn't always correlate with pain. When it does correlate with pain, and I'm one of those that does have a little correlation with pain with osteoarthritis, it often does tie into an acute or chronic inflammation of tissues that are degenerating. So when it is the degeneration is accompanied by inflammation, the inflammation often causes the pain and responds to movement quite well. Movement is one of the best treatments for it. Myositis is a disease that causes inflammation of the muscle by its name. Myo means muscle, situs means inflammation. Psoriatic arthritis, often we know psoriasis by what we see on the skin, but it is systemic. It can also affect the joints themselves. And then rheumatoid arthritis, also known as RA, a common form of arthritis. And we're going to talk about that in just a second. Scleroderma is an autoimmune disease of the connective tissue, and it causes a tightening, almost like water on leather, and it's just going to shrink that leather and shrink the skin. It can shrink the organs. It makes things hard. Sclerosis means hard, and that there is a sclerosis of the arteries. There's a sclerosis of the organs and the different tubes that connect our body, the different connective tissues. And so it's a very painful, horrible disease. And there's different levels of it. Some have very mild, some have enough that it actually leads to death. There's a question here from Sarah, would Crohn's disease fit in this category too? And Crohn's disease certainly is an autoimmune disease. It's an autoimmune disease that affects the gut. And so what happens is the body starts to recognize things that are normal in the gut too as being foreign body and causes an inflammation. So it might be things like gluten. It might be things like dairy. And so often with Crohn's disease, they have to remove all of these food products that they are allergic to in their gut and gradually introduce them again until they can identify what is irritating the Crohn's disease. And the Crohn typically is the bowel, and the bowel often will need to be resected portion of it if it gets serious enough. So let's talk rheumatoid arthritis. So what is rheumatoid arthritis? Well, RA causes an inflammation inside the synovial lining of the joint. So if you remember your basic anatomy, in every joint that has synovial fluid or lubrication and movement has a synovial membrane or lining that surrounds the capsule. And its job is to make sure that there's plenty of lubricant in that joint to make sure that it moves easily and fluidly whenever we're putting load on it or moving it through space. So rheumatoid arthritis in particular targets that synovial tissue and causes an inflammation of it, and it actually attacks it. It starts to eat it. And this leads to problems that are deforming in nature. I remember as a kid when rheumatoid arthritis didn't really have very many treatments for it, pharmaceutical treatments, that people would show up that I would meet and they would have really deformed hands. And I would ask my parents, like, what's going on with that, with their hand? And they'd say, oh, they have RA. Or you would see that they had multiple joint replacements early on, or were using assistive devices. They couldn't grab with their hands. They'd have some deformities and nodules in their wrist and in their jaw and in their elbows. So typically you will see in an untreated form of rheumatoid arthritis some deformation. It literally damages the bone, cartilage, ligaments, and tendons. It goes after them. So it attacks the connective tissue inside the joints. Now, it also affects the heart and the valve in the heart. You can also have a rheumatoid fever and systemic infection that is tied to this. Typically, we know it as being the joint autoimmune disease. And in the United States, it's almost 2.1 million persons right now have rheumatoid arthritis. And it actually starts with people that are younger. A lot of times we classify it as a disease of the elderly. That might be when we used to see the deformities, but the disease itself could start as early as the 20s, typically 30s and 40s, and then progress throughout their life. Women are 3 to 1 as the diagnosis goes that are diagnosed with rheumatoid arthritis. All right, so what causes RA? Well, the truth of it is most of these autoimmune diseases, we don't understand why we have so much hypersensitivity in our world today. So it's still, the answer is not known. What we do know is it's an autoimmune disease where the antibodies attack normal tissue. We know that's what it is. And it's believed that there are genetic components to it. So there's many people that have the gene associated with RA, but will never get RA. So you could, you know how the geneticists go through and they look at things and they identify, and they've seen enough similarities between people with rheumatoid arthritis, and they've identified the genetics of it. But there are also people who have no symptoms and never have symptoms who have that same genetic makeup. So what there typically is in these types of diseases is some kind of trigger, right? So a trigger, what does a trigger mean? Well, triggers could be stress, triggers could be disease, a trigger could be treatment for cancer. The one that is most commonly associated with rheumatoid arthritis is actually smoking tobacco. So we know that people who smoke tobacco for around 10 years and they have the rheumatoid arthritis gene, that they have a higher incidence of full-blown rheumatoid arthritis, adult onset. So these are kind of things that we know a little bit about it. We look at it. We still don't really understand the cause of autoimmune diseases, but this is where we can identify. So if you were to know that in your family history, you had rheumatoid arthritis, smoking would probably be the number one thing that you'd cut out of your life. And maybe things that are similar to smoking, like a job that works in and around exhaust or as a mechanic or those kind of things. We have a question that came in. It says, can RA, similar to other autoimmune disease, go dormant? And with the medications, this is what I was going to get to on the treatment on the next slide. In the treatment, we often can feel like there is no arthritis, there's no problem going on, and have long periods of not having symptoms or derangement from rheumatoid arthritis. So remember how I said the prevalence is greater in women than men. Age onset 20 to 40, 30 to 40, even higher. Incidence at 1% of general population. So we're over 200 million people, 2.1 million people have rheumatoid arthritis in the United States today by diagnosis. The true number of that probably is going to be much greater because we know that the genetic of it is higher and that they have to be triggered to know if they're going to actually manifest rheumatoid arthritis. There is a genetic predisposition with environmental triggers. So just again, to reiterate and summarize rheumatoid arthritis. I have another question inside the chat. Just a comment that they didn't know that tobacco was a major trigger of RA, and that is considered to be the number one trigger for RA. And usually what I've seen in the studies in epidemiology is usually about 10 years of serious smoking with a familial history or genetic history of RA would be the highest risk of actually having RA symptoms. And then somebody asked, Carolina asked, can some vaccines cause or trigger a trigger for RA? And I don't have the answer to that, but if you think about it, any disease is stressful to the system, to the immune system. And basically what you're looking at with a vaccine is you are simulating a disease. So if you didn't need the vaccine, do you have an unnecessary reaction? If you have an autoimmune disease that might trigger it, I don't know. I don't have the answer to that. I'd be glad to look into it. I know some virologists that I could ask that question and bring that back to you, Carolina. So symptoms of RA, these are things that, if you have clients and they're experiencing some of these symptoms, that it'd be worth asking them to maybe go see a doctor or to see a rheumatologist and have it ruled out. And I'll explain why. Some of the common symptoms is that it can change day to day, especially on the early onset. But typically in a joint that is impaired with rheumatoid arthritis, you're going to see a warm, tender, and often red, painful joint. So you can literally see the joints are red and inflamed and very tender to touch. They can lose functional movement pretty quickly, so not be able to grasp things, not be able to bear weight on their hands. not being able to walk with the knees or the feet, and that it can impair their mobility very quickly. When you are in a flare, that means when the episode is at its height, it can often do permanent damage, leading to deformation of joints. And this is why the treatment of rheumatoid arthritis is to prevent that damaging level of inflammation and deformation. So when you look at the medications, you see them advertised on TV, the biological drugs, the methotrexate, different drugs that really help to manage the inflammation of these joints and to manage the autoimmune response. And so we see less joint disfiguration these days with RA because of the medications, not like the 40 years ago. They often experience a weight loss during a flare. They also can have weight gain while they're on steroids. If you've ever been on prednisone or a steroid pack, you notice that you have a ferocious appetite. You are a little grumpy, and some even said they feel horny when they are on a regimen of the steroids. But typically I hear they're agitated. I know I get agitated on steroids, and also I gain weight on steroids. So it's also a water weight, but it's also hungry. And if you think about it, cortisol is one of our main steroids in our body, released from the adrenal gland. Cortisol is sort of our awake and alertness and our driver, right? We wake up in the morning, we have a spike of cortisol. We often have an appetite to break fast, right, after sleeping, so we're hungry. And you can imagine if you're on exogenous steroids, so you're taking them from the outside, injections or orally, it's going to manifest that stage, that heightened alertness, heightened aggressiveness that we have in our day already. So if you're somebody who already is a grouch and you take these kind of steroids, you can be a lot grouchier. If you're somebody who's nice, it might just be less nice, right? So just something to think of. Often accompanied by heart disease. I mentioned there's also a valve disorder that accompanies this when it gets pretty bad. Dryness of the mouth, eyes, and genital area, and Sjogren's syndrome. Sjogren's syndrome is that dryness in the mouth, dryness in the eyes, and often Sjogren's syndrome, people need to have like drops and mouthwashes that lubricate so that they can talk and they can eat and they can engage their normal daily life. So here's some examples of the nodules and the deformation that happens in the joint. You look down here in the picture of the normal and arthritic joint, you can see the synovial lining is in green and the synovial fluid is thought to be blue. So a lot of times when we go to the doctor, the orthopedic surgeon, and they want to drain our knee, if it comes out really clear, it's often synovial fluid. If it comes out with a little bit of blood in it, there's often an inflammation inside of there. And that is an exudate, or sometimes it can even be pussy if it's an infection. We hope not. But a clear sort of bloody sanguineous fluid, meaning that it has a little bit of blood in it, tells you there's an inflammation process happening inside that knee. So the doctor would often drain out the synovial fluid a little bit and then inject steroid into the joint to try to decrease the inflammatory response around the synovium and try to minimize the damage that's going to happen from the acute flare of the rheumatoid arthritis. So typical joints that get affected: neck, jaw, shoulders, elbows, wrists and hands, hips, knees, ankle, and feet. So it's very specific. And even inside the hands, we say the hands, it's very particular to the proximal joints of the hand and to the wrist. So when you see the deformation, you'll often, if you look on the X-ray of the slide, you'll see the proximal joint of the metatarsal, right? The phalangometatarsal joint. That's where you see we call it sclerosing in the X-ray, the whiteness. That means there's an active inflammation and deformation, and it actually damages the ligaments around the joint. So you can see how the joints lose their integrity. This is what happens in all the joints that get affected by RA. And RA is not really picky. Sometimes the rheumatoid arthritis will affect just the hands or the feet and one knee, one hip that might be affected. It's not necessarily all your joints. So that way it's confusing. If you don't know that you have RA and you start having multiple joint problems, but it's not symmetrical, it's like the left knee and the right hand and maybe a little bit of the neck and jaw, you're sort of confused, right? But that would be a very typical finding of rheumatoid arthritis. There's a question on it, says, when synovial fluid gets drained, does it fill back up in its own? And the answer is yes. What happens is there's too much fluid in there. That's what the inflammation is, right? So there is synovial fluid and inflammatory fluid that's coming from the cell wall. And the synovial membrane should always be producing synovial fluid. It should always be making sure there's enough lubricant in that joint to move well. So the last thing I want to do here before we jump into the case, and we're just about perfect, about half an hour in, the difference between osteoarthritis and rheumatoid arthritis. And this is where a lot of people get confused. And I want to be really clear that almost all of us are going to have osteoarthritis. And not all of us, what do we say? 2.1 million. So 1 in 10, 1 in 100, something like that, might have rheumatoid arthritis. 1 in 100, I think it is. So the osteoarthritis affects 21 million Americans. So 10%, that's what it is. 10% of Americans have osteoarthritis. 1% of Americans have rheumatoid arthritis. And if we were to x-ray everybody, we would see that instead of 1 in 10, it's probably 5 in 10 adults over the age of 40. Osteoarthritis usually develops slowly over many years and also is associated with previous injuries. So if I took a poll with all of you and I said, how many of you have sprained your ankle? How many of you have had an arthroscopic knee surgery? How many of you have dislocated a shoulder or had a back injury or neck injury? The likelihood of those sites where we have injuries is very likely to progress into a degenerative change in our body, especially post-surgery, right? So now we look at other things like, similar symptoms. What do we see that's similar? Osteoarthritis typically will be irritated in few joints and may occur bilaterally, where the rheumatoid arthritis affects a lot of joints and often could be asymmetrical or not bilateral, right? Joint redness, warmth and swelling in osteoarthritis. We said there's redness, warmth and swelling in the rheumatoid arthritis. The difference is that with osteoarthritis, if you're like me, you wake up in the morning and you have about a half an hour of slow movement and just moving around, getting these going, do my exercises, get on my bike, take a shower, and I feel almost all better for the rest of the day. Rheumatoid arthritis, that's going to last a little bit longer. It could be hours in the day before you feel good enough to go out and move around. Typically affects only certain joints, as the hands, hips, knees, and spine with osteo, where the rheumatoid arthritis affects a few more joints, right? So the wrists, the shoulders, the hands, and the feet that we wouldn't see so much with osteo. And the last thing here is does not cause a general feeling of being sick in osteoarthritis. It's not systemic disease, it's just wear and tear, compared to rheumatoid arthritis, which is a systemic disease and can often lead to sickness and fatigue and weight loss as it pertains to the disease. So there was a question on the board before we go in the case from Suzanne Martin, good friend. Can you speak to the onset after pregnancy? So as we mentioned, it happens in women more than men, and it happens from the 20s to the 40s that the first onsets come on. So that means that that could be during a time of pregnancy or early child rearing that the disease is diagnosed. And again, childbirth is a major stressor. So any major stressor has a greater propensity to cause a trigger of a genetic or familial inherited disease, right? So what I would assume is that you have two things going on. One, during this end stage of pregnancy, there's massive amounts of relaxin in your blood that's loosening up all the ligaments, right, for childbearing. And at the same time, the stress could be triggering a response, an autoimmune response. So if you had the unfortunate luck that you had relaxin in your blood during the partum, and you also were stressed triggering the RA, that could be a very uncomfortable situation. Now, what typically would happen is from the pregnancy, the body would tighten back up and do its thing. The question is if there was any other damage, and then how would you treat the rheumatoid arthritis? And I forgot to mention, the common treatments of RA now, we know that we use non-steroidal anti-inflammatories, just like Aleve and stronger ones. We use steroidal, so that's going to be cortisone, prednisone, dexamethasone, different types of steroids to control the long-term inflammation. But more recently, we have the biological drugs, and these drugs basically are depressing the immune system. So you'll hear on TV or the radio when you hear these commercials, and they'll say, make sure that you're tested for TB, make sure that you don't have any other infections, because it's going to decrease your immune system, and the diseases are more likely to colonize and take over and have adverse effects. So people who are on these types of drugs often have to be careful of being associated with people who have common colds, like children. So if you're a school teacher of elementary school or a nursery, and you have a history of rheumatoid arthritis, and you want to take a biological, the likelihood is you're going to be always having a cold or some kind of child past infectious disease. So you have to be very, very careful. All right, let's talk about our case. We got a half an hour. I just wanted, can you let me know if that's helpful for me to cover some of the science and the clinical aspect of these diseases before we jump into a case study? Maybe just a little shout out in the chat session would be helpful to me. Or if you think that it's not, you can also give me a shout out and say, Brent, just get into the case. All I want to know is about the case. So take a second in the chat session and just let me know if this is helpful. I like to do what works best for you during this hour. It's a short time. I like to cover a lot of material and to try to get you to have a better understanding of working with different populations. And if you remember, Polestar's vision is to make it so that we're capable and our graduates are capable of working with anybody. We want to make Pilates accessible to everyone. So Jeri thank you very much. Jeri is a 59-year-old female diagnosed with RA now over 20 years. So that means she was diagnosed when she was 39 years old. She suffers from chronic joint pain in her hands, shoulders, feet, lumbar spine, and jaw. Those are all things we saw. Both of her knees have already been replaced, secondary to movement impairments and pain from rheumatoid arthritis. Symptoms include decreased mobility. So she has some decreased ability to move around, decreased strength, decreased dexterity in her hands, grabbing things, opening jars, even eating and holding things with her hands is very difficult. And she does have some chronic foot pain as well, that inside her shoes is very difficult for her to walk long distances. Aggravating factors, initiating movement, like sit to stand, lifting arms overhead. Probably her biggest problem is her shoulders now, as we'll find out. Using her phone, being able to hold her phone in her hand is very difficult. And any kind of computing or eating also is difficult, mainly because she can't use her hands with good accuracy. Walks on average 1 to 2 miles a day as long as she can, especially since her last knee replacement has significantly increased her mobility in the community. So our famous question, what do you believe you are not able to do that you believe you should be able to do? And she says, even though she's walking 1 to 2 miles a day, she's saying community ambulation, sit to stand, dressing, eating, doing things overhead like washing her hair, brushing her teeth, hiking. She really wants to do Pilates, which is why she's coming to us, and travel. So getting in and out of a plane, a car, seats, going up and down stairs. If you've ever traveled to Europe, or you live in Europe, that there is less availability for people with impairments. And so people get scared to go to different parts of the world if they have these kind of impairments. Asked her, what do you believe prevents you from participating? She says, poor dexterity with the hands and feet and pain in multiple joints for hours a day. So she's a very classical rheumatoid arthritis client. I always like to present their medical history because I think it's important for you to also pick up their health history. And in her lab test, obviously she tested positive with the Rh factor for rheumatoid arthritis. Her x-rays show major degeneration in hands, feet, and shoulders. She has a comorbidity of osteopenia due to steroids. So remember, nobody is a clean slate. I always like to remind people that a comorbidity means that, I have this problem, and this problem, and a little bit of a heart condition, and my kidneys are doing this. By the time we're 60s, 70s, there often are a number of other things besides just the musculoskeletal. So we need to make sure that we ask what's going on. So she does have some osteopenia. That's an early onset of osteoporosis. She doesn't quite have all of the precautions or contraindications we would typically put with an osteoporotic case. Medication, she's taken DMARDs, which are what I was talking about, the medication to decrease the inflammation. She's taking steroids and non-steroidal anti-inflammatories, and she is on a biological. So I have to be careful and schedule her when she's not super exposed to a lot of people. Like, she would not be a good candidate to be in a group class with people who might have colds or during cold season or flus. Her surgical history: right knee replaced in 2010, left knee replaced in 2016. So as I mentioned, since 2016, she has been able to walk every day 1 to 2 miles, not necessarily without pain, because her feet cause her pain and her hips are a little disruptive, but that's what she's doing now. So here we look at objective measures for me as a physical therapist. And in her posture, she had a little bit of rounded shoulders, forward head, a moderate kyphosis, and her gait was a little antalgic. Antalgic means that pain is causing a change in the way she walks. It's not necessarily a specific pattern. It is just a pattern that is not normal because of pain. In her active range of motion, both her shoulders were limited to just below 90 degrees, or just below what we would do in our goalpost exercise without having pain. She couldn't get her arms up. She was suffering from impingement and weakness in bilateral shoulders. Her external rotation was only 45 degrees. She had pain at the end of her range, poor foot and hand intrinsic mobility, mild deformities of her toes and fingers, and her knee range of motion was normal, 0 to 130 degrees following a total knee replacement. So this was a normal thing. So it's good, right? I mean, the new knees are allowing her to walk. If she hadn't had those knee replacements, she would pretty much be locked into her house. She wouldn't be able to leave. Strength, bilateral upper extremities were a 3+ out of 5. So remember, in the muscle scale, anything that you can do to lift your arm up against gravity has to be more than a 3. So a 3 says, I can't lift my limb or my body part against gravity. I don't have enough strength to do it. It's not a range of motion. It's a power thing, right? And so she is able to lift it up, but if I put any resistance whatsoever on her arm would fall down. So very weak, very poor mobility, very poor strength. Neurologically, she was intact, both in sensation and nerve reflexes. And then jaw mobility, she had decreased opening and left excursion, more pain on the right side, just as a side note. We're not going to treat her jaw in Pilates today, but we just need to be aware that eating, talking could be painful to her. So limitations, physical limitations. We're thinking of our sort of like the Nagy grid, or we're thinking of the ICF model if you're in the rehabilitation world. Her physical limitations: decrease active range of motion, bilateral upper extremities. I think that's going to be my #1 goal. So if you're taking notes when we go into the interactive part of the Mentimeter, know that bilateral shoulder mobility, really important to her. Don't really want her to have shoulder replacements because they're not as successful. Want to see if we can get that range back for her to do her functional activities. Decrease hand and foot dexterity and strength. It's going to be hard for us to do a lot with that other than treating symptoms, doing some intrinsic exercises to try to preserve some of the strength in her hands. Jaw opening and closing restrictions, and then decreased knee flexion bilaterally, only because of the prosthesis. I want to make that clear. Even though we'd like to be able to kneel down on our heels, after you've had a total knee replacement, that's just not possible with most of these prostheses. I keep waiting for them to come out with a new prosthetic that's going to allow full flexion. I think they're getting close. So I'm going to hold out a little bit longer on my left knee. Psychologically, fear of doing Pilates. She really wants to, but she's afraid that the Pilates might be too strenuous for her or might flare her up. So we have to figure out a way to teach her that she's going to have a positive movement experience without pain, without a flare. She's also discouraged due to decreased activity and lifestyle. So she always has been a very active person. And now all of a sudden she can't be an active person, right? She feels like her activity level is really low. From a functional standpoint, prolonged standing and walking are uncomfortable. Phone and computer skills are limited. We take for granted that we can send a text. She said that it's almost impossible for her to do a text without having neurological symptoms in her wrist and weakness and numbness in her fingers. So imagine living in today's world. She's young, not being able to have that dexterity. Overhead activity, grooming, dressing, all very challenging due to the shoulders. Not recreating very much, would like to do the Pilates, and she'd like to be able to eat without pain. So the physical therapy treatment in those 4 to 10 weeks, I did a lot of education, pain and healing education for hands and feet, teaching her how to be able to listen to them and how to know when is too much and when is not, and how to do little exercises in between her work periods and things that she can do to increase her hand mobility. Postural education, you saw she has kyphosis and a forward head, so taught her things like bed mobility, sit to stand, shoulder girdle mobility, working on some subtle extension in the upper thoracic. Manual therapies, we restored 90% of her range in her shoulder girdle and glenohumeral joints. So we have the range, but we don't have the power yet. So make note of that as we start to design together a Pilates program in the continuum of Jeri's care, what are you going to focus on? Can you focus on things like using the tower bar to be able to re-educate that new shoulder range of motion? Are you going to use closed chain of the foot bar in some quadruped exercises? Are you going to use some pseudo closed chain activities on the chair, maybe where she's laying on her tummy over a pillow and working a little bit on some pseudo closed chain activity with the pedal? I'm thinking of that. And then I also was able to restore about 50% of her TMJ mobility in all planes. So she's eating with less discomfort, and doing pretty well. Plan is I want to refer her to you and to continue with her whole body movement and focus on spine, shoulder mobility, postural awareness, and a gradual return to some of her functional activities and gradual restoration of her shoulder function. And so we're going to use Pilates. She wants to do Pilates. She's just afraid of it. We've just been working on educating her and getting rid of the fear and getting her excited about working with you. Before we start the assessment process as a Pilates teacher, based on all of the subjective and information to this point, what would you hypothesize Jeri needs the most right now? So take a second and let's see what your thoughts are. What are things that Jeri needs now? While you are getting into here, I just want to bring out some points of a very important point about working with individuals that suffer from rheumatoid arthritis. Typically, they can do everything that they feel comfortable doing unless they are in a flare. So when a client is in a flare, we as Pilates teachers and physical therapists and even physicians have to be very careful with the load and the activity that we ask them to do. Because in the flare, there is destruction to the tissues. You can imagine, feet in straps, long springs, downward dog, those kind of things that maybe they could do normally without a problem could potentially cause an undue stress on the tissue and could lead to some additional tissue damage. So we're very careful not to put excessive stress through the tissues, sometimes even take a break while they're in a flare. Melissa, go ahead and show the screen. Let's see what people are saying. So we have movement control, power, shoulder strength and back extension, pain control, positive movement experience, pain-free movement, positive movement experience. You guys are getting less fear to participate in Pilates. I think that's a crucial one, right? These positive movement experiences. If Jeri can find a safe place to be able to move and feel like she's doing an activity, the likelihood of her continuing the activity is very high. Gentle movement to restore confidence, roll down bar with low springs, gentle movement, yes. So we just want to get her moving And my goal typically is to see if I can get a full 50, 60-minute movement program without her fatiguing or becoming uncomfortable. And there really is nowhere better than Pilates to do that. I do strongly suggest, however, that we stick to a whole body exercise. Don't get stuck in just working with the shoulders. Let's go to the next slide. Thank you, everybody. So what functional test would you want to do? So remember, we talk about, and it doesn't have to be the Polestar assessment tool, but what are some functional things you would want to see from her to be able to know if she's doing better or not? So back into Mentimeter, away you go. We had a really good course this last weekend, 3 days with everybody there, that we were basically going through this process over and over and over again ad nauseum of learning the Polestar assessment tool, learning how the ICF model, or the International Classification of Function model, could help us determine their level of participation. And then we integrated the principles of movement to show, is this a mobility issue? Is this a coordination issue? Where do we think the problem is? And then we went to the far end of being able to design programs with all that new information, interviewing skills. So this is very important to know, as we talk about in the practice act of Pilates. The number one element is, are we able to assess and design a program for our clients? Number two is, are we able to use all of the repertoire and understand the history of Joe and Claire Pilates? And number three is, can we reassess and modify the work? So that is within the Pilates practitioner sort of act, what we believe is defined, what our skill set is defined as, to be able to work with our clients. Let's go ahead and bring it live, Melissa, as they bring it in. So a 6-minute walk, that'd be interesting. She walks 1 mile to 2 miles a day. It'd be interesting to see how far she walks. Sit to stand, goalpost, great test, right? Both of those are very appropriate for her based on her complaints. Inhale and exhale breath assessment. I think breath would be a great place to go. Squats, maybe some half squats or half lunges with assistance. See how those new knees are working, right? Modified sit to stand, we said, squat, goalpost, half kneeling. You're on the right track. So what I chose was goalpost, sit to stand, seated rotation, and side bending. I probably should have put breathing in there. Now looking at what a lot of you do, I learned a lot from you as well as you learning from me. So know that this is mutually beneficial for us to be together. And then I looked at modified shoulder movement. I wanted to know what you could do in different ranges or orientations of gravity that are functional, right? So what do you believe could help Jeri regain her ability to walk without pain or fear? So we're talking about walking. What are some things that, based on her inability to walk too far, a little loss of dexterity in her feet. By the way, her goalpost, she was able to get the head within 1 inch of the wall, and her arms were up, but they were not touching the wall, and she could not do the V. So even though I have a passive range of motion, we still got a ways to go. And the sit to stand, she was able to do independently and was able to do it quite well. So her knees are definitely working better. And still the problem is any kind of prolonged standing, or she'd like to walk 5 miles and go hiking. So right now she's 1 to 2 miles a day. So what do you think? What do you believe could help Jeri regain her ability to walk without pain or fear? How are we going to wake up those or decrease the pain and the fear component that she has? Let's go ahead and let the screen come up. We'll just start letting people put it up there. One is feeling that fluid movement, use music, more fluid movement like dancing, love it. Strengthen legs with footwork, hip work, get movement, yep, non-weight bearing walk and pull, great idea. Single leg stance activities and balance. Balance exercise, rock the boat standing over a recumbent gluteal exercise, good, I like that. So again, using some modified load, using some alternative rhythm motivators, working on some strengthening, things of going up and down, maybe some steps, building her confidence, breathing. I like that one down there. Confidence, firstly, breath, work foot intrinsics, foot mobility. Good. All on the right track. So here's a little insight. Jeri's restriction of thoracic appears to be much more related to fear of re-injury. Fear of injury and pain can completely change the movement strategy. Goal is to shift Jeri's paradigm to movement equals relief and joy. So we really want to get rid of that fear, and you guys sort of hit it on the head by creating these positive experiences of movement. I love the idea of water. I think water is so powerful and can create a lot of positive experience. Like she could even jump in water. She could run in water where she would never be able to do that on the land yet. Yeah. How can we help Jeri regain her thoracic mobility and re-educate her shoulder girdle mechanics to provide function without pain or fear? So we're coming back up into the upper body. What are some things that we can do? Also, while you're taking a moment to write your answer here, we have a number of workshops that are going to be coming up. They're going to be virtual. I think Shelley mentioned one last time. It basically is dealing with the effects of sitting on our bodies. And we're going to be talking of the old adage, sitting is the new smoking. We're going to be talking about how do we influence our community and our clients to sit less? How do we influence them to move more and create these positive movement experiences for them? So that's going to be coming up on July 8th. And when you get to post-production, whether you're listening now or listening later, there is a very special promotion just for the webinar attendees for you to be able to join us. Let's open it up and see what people are saying. So scap series on the tower bar, push throughs, you got a book opening, scarecrow. That's a very difficult one for her, right? So if we're working with her, maybe with a pillow or an oove under her chest, so she has some range to work on that scarecrow, great exercise. Arm circles and rowing. A lot of times the tension actually makes it easier for her to move her arms in different directions, or the assistance. Or we do the sort of trick where we engage the latissimus and we work with an eccentric load as the arm goes up and down. And she starts to realize that she has control, wakes up some rotator cuff muscles, great thing. Transitional diagonal rotational work. I have had positive results using arc and bar roll down. Love that. Yep. Get that thoracic extension and the arm and shoulder mobility. Very good. Excellent, everybody. So when we think of principles of movement, breath, mobility, dynamic alignment, control, and coordination, what principle of movement would you prioritize for Jeri right now? This one's a quick one. Just get in there, identify it. We're already getting to the point where we got some great ideas of what we're going to do to increase her ability to walk, increase her ability to do overhead activity. And it often helps for us to also have an idea of what principle we're going to be addressing with them. Let's go ahead and show it, Melissa. So I like that, breath and mobility. Yes, indeed. So she has, remember, we can't manipulate her joints, right? Not with rheumatoid arthritis. But what we can do is educate movement, right? We can help with her best alignment. But one of the most powerful tools of mobility where we need it is breath. So I love the fact that breath is number one right now. They're all important. Trust me, every principle can always be used. Control is going to be your power. So we talked about increasing her strength in her hips. Her hips are good joints. Her knees are good joints. She wants to walk. Her feet are not so good. So we want to be able to get a little more dexterity and mobility in the foot so that she can tolerate the load or the control of walking further. We also get her in shape so that she has longer endurance with her breath work. Very good. So in summary, and this is where we'll stop today because I think we're out of time. Yes, we are. We're going to focus on functional activities for Jeri overhead. So we're always going to go back and see if she's doing better with her dressing, grooming, overhead activities. And then we also want to make sure that she's walking and standing without pain or less pain. Doesn't mean she'll be without altogether. Structural limitations, we're going to increase that thoracic mobility in all planes. We got myofascial restrictions in chest and shoulder girdle that we're going to try to open up the pec girdle in her shoulders. Remember that even coming up overhead, that pec minor, pec major, latissimus, all of those muscles might be part of what she perceives as the restriction in those joints. So by doing the work that we do on the Pilates and the tower bar and the pedal and the straps and the springs, all the things you mentioned can start balancing out the tensions and the mobility of those tissues around the shoulder girdle. Strategic limitations, poor shoulder girdle and thoracic mechanics, confidence and ability to move without pain, and discovered benefits of Pilates exercise in her life, right? So I hope you enjoyed this session. Again, I wanted to bring in a little bit of more science and more clinical practice to it. I want to really work. I guess my goal is to make this continuum really applicable to everybody that comes in, to see that I can work with my Pilates teachers and yoga teachers and geritonic teachers. As a physical therapist, my teachers can work with me at any time they see somebody that has a pathology that maybe needs some additional assessment or some mobility, structural work, that we work together. So in all of your communities, I'd like to strongly encourage you to, build those communities. Invite people who might not understand what it means to have a continuum, right? None of us are equipped to handle every client that comes to our door. We need to work as a team. We need to have mentorship. We need to mentor. That's how it works. And this is what we stand for in Polestar. We want to, again, make Pilates accessible to everyone. I hope you enjoyed this session, and I look forward to seeing you next week. Next week, we have a very special program, 2 guests. We have Petite Pilates from France that is going to be joining us, and we're excited to have them. They're getting excited to come on. They've designed a beautiful program for children and young children, even preschool age children, using some unique props, some unique cards, some unique theory and philosophy that they've incorporated that I personally am very excited about. And as we meet with them, they're going to share with you what they're working on. And we hope that we can somehow bring their work to other parts of the world, that we can share that information and make sure that we're able to work with our children all around the world. And again, making Pilates accessible to everyone. So today's a good day to have a good day. And lastly, just to reiterate, be kind. Do look at the post production. There are special discounts for you that are very significant, as high as 50%. Some might require a little bit of action. And we'll see you next Thursday.